Okay, good afternoon, everyone. We want to welcome you all. I know some of you are still joining, but we want to welcome you all to the first of two webinars on trauma teletherapy for youth in the era of COVID-19. Our presenters today are Dr. John Briere, the Center Director of USC-Adolescent Trauma Training Center, and the developer along with Dr. Cheryl Langtree of ITCTA. We also have Amy Escott, LPC, the MOACT's project director for the Children's Advocacy Center of Greater St. Louis, also a Category 2 center of the NCTSM. So with that, I'm going to hand it over to our presenters.
Welcome everybody to trauma teletherapy for youth in the era of COVID-19. As you know, there's two parts. Each one will be 1 hour, and we'll give you a little information at the end about the second presentation. Amy is co-presenting this one, and Cheryl Langtree will be co-presenting the next one. So the central, perhaps one of the major reasons why there was a pressing need to engage in some version of teletherapy for youth right now is that many of the traumatized kids we see are carrying around a lot of current risk, have a lot of problems with marginalization that keeps them from being able to access therapy in the ways that maybe other kids would be able to, et cetera. So we thought we would just start with explaining the problem here. Many of the children and adolescents that we see with in clinical work have abuse or trauma histories, and these trauma histories are presenting with current symptomatology, but unfortunately, the classic way that we had used to address kids' problems in this area was to use face-to-face, one-to-one therapy. In light of current social distancing, we can't really do that anymore, although we'll talk a little bit about the end about transitioning back. And so what most people are using now is some kind of a teletherapy model, either with phones or with video devices or with computers, so that the youth can receive therapy at home or in their living facility, despite the fact that COVID is ongoing. One of the things that this little presentation about is we surveyed really a lot of therapists and got a lot of feedback from our own ITCTA monthly consultation group and other groups about what people were struggling with and what we could do about it. We also then searched the literature and looked at all of the professional organizations and packaged therapies out there that have already introduced some guidelines or information on using teletherapy as opposed to face-to-face. The problems here are obvious. One of them is will kids who are somewhere else and interacting with us over a screen, will we be able to form good enough rapport with them? By the way, the interesting short answer is all of us have had in our experience, I think Amy's smiling about this right now, it's not really the kids that are having the problem, it's the therapists. The kids have been staring at small screens forever, so to them, this may not be as much of an issue. But you know, there is no question that some kids with more severe attachment difficulties may not feel as connected with therapists when they're looking over a screen. Obviously, we have to somehow take into account the fact that when the kid is interacting with us over a teletherapy platform from their own home, there's less that we can do about any danger they might be in there. You've probably read or seen or interacted with clients who told you that in the home, there's probably increased child abuse, increased intimate partner violence, et cetera, because we don't have as much as surveillance from outside community figures, plus the fact that it's much harder to escape when you're in some sort of a COVID situation. Another potential problem is that in many cases, there's reduced privacy. It may be very hard for a kid to find a room in the house or an area where they can interact with their therapist without someone hearing. Also, some of the kids that we see, of course, are in some kind of residential setting where it may be especially hard for them to accomplish that. This has led kids to all kinds of creative solutions, including going into a car outside of the home, using cell phones, which are not optimal, far away from people. But again, the danger is as they move away from their home, then they're more in danger of COVID-19. One of the things for the therapist is that often when she or he is working with the client, she may have less acute, moment-by-moment, real-time feedback of how the client's doing. This will be important at various times, especially perhaps when we talk about using exposure therapy in this regard. I think that's in the second one of these, not the first one. There are obvious socioeconomic barriers here, and it's all over the United States, it's all over the world, which is that unfortunately a lot of the kids we see are socially marginalized. They're struggling with poverty, they're struggling with inadequate access to resources, and that can mean that they don't have some kind of a device in which they can interact with us very well. Phones are probably the worst, but people do it. Tablets are pretty good, computers are probably the best, but you can imagine a lot of the kids that we see who are in such difficult straits, the fact that the possibility of getting devices is a little harder. Now, a lot of states and counties and cities in the United States are starting to buy devices for kids so they can use them this way. Our work at USC, for instance, in the burn unit, where I also work, we now have iPads so that the burn people can talk to their family members or others outside, but also so in some cases consultation or evaluation can occur. And then, the therapist, as we'll soon see, is a very big part of this. How are you doing? How are you handling all of this, changes in role and technology, et cetera? For some of our therapists, I would clearly be an example, although I'm sort of a computer nerd, I found a very steep learning curve on using Zoom or Microsoft or one of the other ones. It just can be sort of hard. So we have two phenomena here. We have the therapist is now, when they were working within an office or another context, maybe if they went in private practice, they had support and validation, which is very important, obviously, in working with traumatized youth. And they didn't have to learn anything new about how to do the work. So we take that into account as well. Everybody says this, but it really is true. First of all, self-care. We have to have a way that the therapist can function well enough and with enough groundedness and support and enough of an existing platform that they can do the work even though things have really changed from what they were doing before. Many therapists who are in clinics are now sitting and doing therapy in their living room or their bedroom, although we'll probably mention they'll go in the bedroom sometimes, but someplace in the house. And this creates problems because, of course, for many therapists, they're also parenting. They, as you know, there's now been research on sort of Zoom psychosis. They don't call it psychosis, I do, but as some of us know, if you do too much Zooming, you kind of go into a weird technologic dissociated state. And it's an actual identified phenomenon. Zooming actually is bad for you at high levels. So if you are used to seeing 5 patients or clients or 8 clients a day, this can be really pretty hard. So this is things that people have told us and things we've come up with as well. The first one is it's probably really important to differentiate your home from your office, which is that most people who report more success here report if they can find an office or something that's completely separate from the house, hopefully their own office if they have one, but not something that's been set up in the house with your own marked off area. Ideally, a situation where you can tell the difference between just being at home in a regular sense and doing your work. Why we need this boundary is interesting, but it does seem to be true that we can go to a sense that we're in some separate space that's going to be helpful. Apropos of that, a lot of people have mentioned establishing regular routines. If you normally get up at 8 in the morning, get up at 8 in the morning. Dress for work. We have 2 incarnations of not dressing for work. One of them is you use a virtual screen and you don't dress at all, and I really don't recommend that too much. And the other one is that people are dressing very casually, which makes perfect sense, but it looks like it matters to us if we dress in our grown-up clothes. It looks like it's telling us we're professionals, and it grounds us in our training and our background and our identity. Also, we've heard anecdotally from kids that freaks them out a little bit if we're wearing t-shirts and stuff, because boundaries, of course, are very important for a lot of our kids who've been hurt in a variety of different ways. And if we start looking like we're varying the boundaries, then that's going to cause them to be more concerned. We recommend you space sessions. And now here's where, it's the art of the possible. If at all possible, you should probably have at least 10 to 15 minutes between sessions. And so if you have an hour, then that would mean you get a 50 or 45-minute session. If you have longer, then it would be shorter, different periods. By the way, we don't actually recommend you extend sessions too long. A lot of therapists are experimenting with having shorter first session. And I think that's probably good both for the therapists and clients. And then also, if you can, intentionally schedule yourself to not have back-to-back sessions whenever possible. So if you have 3 clients to schedule, the anecdotal data from lots of folks is don't do 11, 12, 1, do 11, 1, 3 if you can, or something like that. It can make quite a difference. Among other things, just even in therapy, it's often hard to shift to our next person if we were just very recently immersed in the difficulties of their last person. So to arrange those kinds of things. For those of you who have kids or pets who are roaming the house, some of this is going to be a little unavoidable, and we'll talk about that soon, but would be to officially, just as officially, spacing sessions, establishing routine, that you officially work out some way that someone will be taking care of your kid or taking care of your pets while you're doing this work. Of course, some of us are self-isolating on our own, and so that's not going to be as possible, but the issue of kids crying and screaming during the session when the therapist is working is probably a nightmare for all of you who've had that kind of thing happen. Or a cat or a dog comes in and Zoom bombs your session. It's probably not so bad. In fact, some of our colleagues, and Cheryl Langford mentioned this to me, that sometimes clients like it when your patient Zoom bomb feels real to them. But you know, these are all complex things we need to think about. Can you find a way to keep that constrained? And then physical self-care, you know, I'm the last person to be able to lecture on this since I'm bad at it myself. But can you have a daily exercise regimen, which means yoga or some kind of working out or something, or even walking around the block or something? It looks like it's helpful to go outside, that our brains just don't like being in rooms staring at screens for too long. So even walking around for a few minutes, a lot of people gave us that feedback in our consultation, is that if you walk outside and you can breathe the air and see the sun, that it may reset your head a little bit. Monitor alcohol and other substances. No, obviously during the sessions you wouldn't do that, but one of the side effects of the COVID-19 pandemic, which it's experiencing some of the other ways we're dealing with COVID right now, is that alcohol and substance use is going up. And I'm not making moralistic judgments about that, but if you do use a lot of substances or alcohol, you're probably going to get into a bit of a numbed out avoidance style, which is really not good for you. The classic advice for people in the COVID world is to monitor your substance use and keep it at low levels, because you can end up sort of shutting yourself down. And then just as we say this in DBT to clients, we want to say this to therapists too, which is to attend to healthy eating and sleeping. If you normally eat a certain hours, we recommend you still do that. Make sure that you get whatever number of hours sleep you need, and we all vary on that kind of stuff. Those things really matter. Probably this slide seems sort of like obvious, but I would report this was a lot of people told us that there's something about so many things are changing in the world. At least try to make it as limited as possible. Can you work on an established place? Can you wear your regular clothes? Can you space your sessions? Can you keep other things from intruding, and can you take care of yourself? Emotional self-care, I'm going to say a little bit, and then I think Amy's going to speak in this slide. Is that true, Amy? Yeah, okay. So emotional self-care just basically means that you take time to take care of your emotional needs. Some of that was presented in the last slide, but a lot of people reporting that daily yoga or meditation or prayer sessions or mindfulness exercises can be very helpful at these times. Not all of us engage in some kind of contemplative practice, and that's fine, but if you can find a way to get a little time for introspective, inward focused attention, to show compassion for yourself and compassion for others, and to allow yourself to settle in. And this list here actually comes from Randy Semple. These are a number of phone apps kind of accomplish this for you. Some of them cost money, some of them are free. One comes from USC, some don't. And one of them, Liberate Meditation, actually was developed specifically for people of color and marginalized communities, in the sense that it avoids some of the irritating white stereotypes we sometimes see in these other packages. Easy to say, but take up a new hobby, a new extracurricular activity, read a new book. It's really kind of interesting how many of us are starting to read a lot more and share our books with other people. We're sort of doing ad hoc book clubs, or maybe even official ones. But again, this is the idea that you won't spend your whole day just staring at a screen, that you do things to shake things up. And that this is not just some precious thing. It's a reality of we're studying this and discovering that people's capacity to function on Zoom or other platforms decreases as a function of hours they do it in a day. So anything you can do to break it up, it's probably going to be good. And then things like cooking, gardening, writing are activities. And then I totally can't do the last one. I don't know about you guys, but intentionally limit your exposure to news media. I obsessively look at things all the time, but it's not good for you. It's been established. It's actually not good for you. So if I were, it's so far from me to tell you what you're going to do, and I'm not going to do it. But it does look like if you're looking at the media too much, you can depress yourself or wear yourself down and make yourself feel ways that may not be actually that helpful to you. Did you want to say some stuff, Amy?
Yeah. So I just wanted to build on what John was saying, that what has also been helpful for our team, as well as a lot of the teams I consult with, is pushing ourselves with self-care to also how can we be as well as possible within our work. Because so often we want to just do whatever it takes to do right by our clients. But especially when we're living and working in a global pandemic and learning teletherapy, it's also important to think through, like, what is it that I as a provider need right now? So if I am working on a grounding activity with a client, I might suggest a grounding activity that will help me feel more grounded in that moment. Or I might have tea or something that will help me feel better within the session, rather than just kind of muscling through and then having to recover at the end of the day. So being thoughtful about what are those messages we're saying to ourselves. The other example I like to use, I had a client who did session in a hammock, which is where she felt safe. It's where she felt comfortable, but I'm sure you're guessing what's coming. I got nauseous, right? And as much as I wanted to let her be in that hammock, I could not do back-to-back sessions being motion sick. So I did have to sort of say, wait, what is it I need? I need for her to move a little less. And then I had that discussion with her, and she was very responsive to it. So just thinking about what can you do when you're actually in a trauma therapy session to help promote your wellness throughout the day.
Great. By the way, this goes without saying, this is a whole manual we're presenting to you in little pieces. And Cheryl and Amy and I it's a pretty inclusive manual, so we're only touching on things here. A lot of what Amy's talking about, for example, there are whole sections of our manual for that. If you don't have the link, we could maybe put it in chat, or we could, you can just, it's on the last slide. So part of obviously what is changing now is that our kids were always in danger. They were in danger in their home, they were in danger in their environment, they were in danger in a racist, sexist, homophobic, transphobic environment. They were in danger from their own attempts to deal with things, sometimes in ways that are problematic for them, avoidance strategies. That was always true, but one of the things that we have to do now is modify our teletherapy interventions, not because of the teletherapy component, but in the context of doing teletherapy. We're probably going to have to do more attention to making sure that those kids are safe. They may be in a different room or a different house than they were last week. They may be on the streets. We need to know about those things. The parents may be listening in. Abuser may be in the family abusing someone or abusing a client. So those issues become bigger. So ongoing abuse, unsafe living environments, as is also true for partner violence we're seeing right now throughout the United States. Because people are constrained at the home, potentially under an abuser's control, the abuser is more able to victimize them on a regular basis. We don't have, first of all, we're not seeing in our office where they're going to be safe. And second of all, we don't know unless someone tells us what's going on outside of what we can see in the camera of our device. And then obviously there are COVID exposure risks. A lot of kids who are lower down on the socioeconomic scale are going to be living in more crowded, impoverished circumstances where there's less opportunity for social distancing. The caregivers of many of our kids are these essential employees people are talking about. It really just means you have to work while other people are able to social distance, which means all those people out there that are cleaning houses, doing all the things, the healthcare workers, et cetera, when they return to their homes, they may be more likely to spread the virus to the kids, so we have to worry about that. And then just there's less if you're not in an established environment, it's harder for the system to detect whether you're safe or not, child protection, other people to know whether you're wearing a mask, what you're doing, et cetera. So the general notion that we can't tell what's going on with you also makes a problem for us in terms of maintaining your safety. So this brings us basically to in-person versus teletherapy. I know that some of you out there right now are doing in-person therapy. You know, you work that out with yourself and your systems, but you know, the issue is that for many cases, it's not possible. Also, many therapists fall into the pre-existing medical condition thing, either by virtue of chronic ailments or because of age. And so it's really important, as Amy sort of said in the last slide, that you take care of yourself first, which is even if you feel that you know, that you're okay with doing this in an individual therapy perspective, remember that you are taking some risk there, and the kid who's coming to see you is taking risks as well. So a lot of what we stress here is assessment of immediate danger, location, and privacy. So I know this first one's going to seem awkward, and maybe you don't have to do it if you know differently. But what we do recommend is at the beginning of each session, you ask the kid where they actually are, what the actual address is, and what phone number there is available. Again, that's going to freak out some kids. And if you know they're where they always were, maybe you don't have to do that. But it is coming up that a kid is in some kind of danger, and the therapist wants to intervene, but they don't even know where the kid is. So, and you know, what you can do sometimes with this kind of off-putting stuff with clients is just announce at the beginning of the first session, say, yeah, I know, you know, you're probably gonna think this is stupid, but we're just trying to keep everybody safe. So I know, would you just humor me and tell me at the beginning of the session where you are, et cetera, et cetera. If they're using a cell phone, by the way, don't ask for that phone number, ask for another phone number that's in the house. An interesting advice we got from someone on one of our groups, and people have really liked this in our presentation so far, is working with the client to develop code words. And they're nothing big, but they're just a word that the kid would probably not normally use that signals that there's ongoing danger in the environment. And perhaps another code word for when there's not danger, but their mother or father or sib or something is listening behind the door, sitting in the room, or saying, I'm not going to leave, I want to find out what's going on in therapy. So these code words usually are things like, I feel hungry, or gee, it's hot in here, or you know, whatever would look okay, but wouldn't be what the kid would normally say. Out there in the endangered environment therapy world, there's often the single code word for danger. So when the client says that, then we know something's wrong. This listing other, though, is probably pretty important, because it's probably more likely that that's going to be a problem for kids, which is they're going to want to talk about safety or issues or sexual abuse histories or something, and somebody's sitting in the same room or with their head against the door, which we've already heard about it from another room. And so if we can have those code words, and then, by the way, working out what does it mean when the code word happens. And you'll have to see this more in the manual, but if you say the code word, then these are the things we could do. You could get off the phone, you could hand the phone to the person who's listening so that I could talk to them. You could have me, you know, whatever it is, to work out some kind of way. So it's just using the code word and then sitting there. Now the therapist is freaked out. The kids told you stuff and you haven't really gotten anywhere. So figuring out what to do with that next. Sometimes people refer to headphones in here, that if the kid is wearing the headphone, they can't hear what the therapist is saying. That's true, but the blowback on that is that some traumatized youth and actually adults feel very freaky about wearing, well, that was a technical word, freaky, very upset about using headphones because they may not be able to hear whether someone's sneaking up on them, someone's opened the door, or someone's screaming at them from another room. So if headphones works, or you know, or whatever listening device you might have, if it works, it might be a good idea to reduce the chances that others can hear the therapist. But you know, in my view, I don't think you have to go there. I think it's up to you. It really depends on how it works out for the kid. Safety planning actually came originally from the so-called domestic violence literature, the intimate partner violence literature, which was, how can we, when we're working with women or men who are in violent situations, is there a way that they can be prepared to escape if they need to be? A lot of times people say, I don't need to escape, I can handle the perpetrator, the abuser, whatever. You know, and the typical way we respond to this, I'm sure that you're true, but would, you know, again, humor me. Let's work out these ways so that if something does happen, you can use it. I'm not telling you you have to use it, it's just that it's available. And by the way, what we often hear later is A, clients sometimes needed those things, and they're awful glad they did it. And B, it does actually make them feel safer. Although they're taking the position of, no, this isn't a problem, I'm not worried about it. the reality is that that they are scared, and this is a way to get better feelings. Part of it is ways to leave the home safely, so a clear path of escape. How would you do that? When would you do that? Many people have a packed bag. I don't know if that'll work out in your constellation, but for the kid or for an older person who, if they are escaping, would they have some stuff that they could have, especially a mask. But also sometimes people have a cell phone in there, or food in there, or other things that would be helpful. Usually that packed bag has to be hidden, by the way, because it's a warning to the perpetrator that nothing's going on. Pre-arranged agreement to call or text safe people in the community who can be called on. So literally this means in safety planning, you say, LaShawn, is there anyone that you know who, if you were in trouble right now, if you text them, you could go to them right away and you'd be safe? So, you know, in the age of COVID, sometimes people don't want kids coming into their house, and I fully understand that, but it has been helpful already, and I think it is an important thing. Is there a way for you to find someone else that you could go to if you had to? And you can work it out with that person that if there is a place they can go, maybe that they go into the front room, and with a house where they're at, of the apartment, nobody else is in the front room but that person. So there is some social distancing. And then can you call the police or other law enforcement? For a lot of our kids, this is an ambivalent act because the police may not be perceived as their friends. They may have perceived them actually as having victimized them or people they care about. So, you know, don't just say call the police and law enforcement. You have to do it. But recommend using 911, figuring out, maybe even talking with the police about how would be the best way for a kid to contact them. Sometimes there are liaison officers and others who can take those calls, etc. There should probably be some kind of plan for reaching the therapist, a crisis line, or a mobile crisis team during an emergency. So we would normally do this in working with kids, but because there may be more likelihood of danger to kids right now in the COVID-19 environment than before, even though there's danger always. Explicit arrangements for reaching the therapist or others. Some of you don't want your clients to call you at 2 in the morning, which is perfectly valid, but to outline the parameters of when they can call you if they have to, or maybe when they can text you, it's up to you. Working out ahead of time, what crisis line could they call, you finding out the information, giving them the phone number. Mobile crisis seems pretty heavy duty, but we do have situations in Los Angeles, I can tell you, where it blew up into a hostage situation or blew up into a very dangerous police involvement situation. Mobile crisis teams are often the best people to be involved in that kind. Ranging and locating and pre-arranging where they could go for shelter if they need to. Again, we're running into a sad dynamic. It may vary by community. You should work this out beforehand. Some shelters are now closing because they don't want any more COVID risk. Some aren't. So it would be good for you to talk to people and find out who's who and what they should do. And I really mean this. If you just say, call your local homeless youth shelter and don't give them the phone number, they're not going to do it. And it may be that shelter isn't going to be open to a phone call, and then you kind of just put a failure experience or a further endanger experience for your child. So work it out ahead of time. This you'll have to go to the manual for, but can you work with clients to reduce their harm? They're likely to cutting, using substances, engaging in problematic sexual behavior or other ways, because these we find that the stress reduction behaviors are on the upswing right now for abused kids, and which means, can we just talk to you about you know, what could you do if you felt suicidal? What could you do instead of cutting yourself? If you want to drink, is there someone you could call instead of time, instead of doing that or whatever? I do a whole workshop just on that point, so I feel a little weird going on to the next one, but there you have it. Teaching kids social distancing, infection prevention strategies. You might think they get it, but sometimes if they're raised in some families that, for instance, deny it or think it's a hoax, or have superstitious beliefs about what COVID is or how to treat it, you know, it's going to be very, just as we suggest when working with sexual abuse survivors that you integrate safer sex protocols in your therapy with sexual abuse survivors who are engaging in externalizing sexual behavior. This is, you know, masks, social distancing, etc., not in a controlling authoritarian way, but just in sort of a helpful, caring way. You know, I don't think the kids have that many objections to it, but they may be hearing things from the parents. And then debunking pandemic myths. So this is the stuff, please do not drink the things that people want you to drink, whether they're cleaning fluids or whatever. You can get, masks do not in fact increase the likelihood you're going to get sick, all these kinds of things. And just, I would check it out with everybody, because especially because a lot of these kids are heavily on social media. And if you just drop into social media on the number of different opinions there are about COVID and what to do about it, it's truly frightening. So who knows what they think? So do that a little bit. A big issue here is increasing psychological safety, and this is actually something that Amy was very involved in our manual stuff, and she'll actually continue this on for in just a little bit. But increasing psychological safety means basically working with the client so that they can feel safe when they're in some ways manifestly unsafe environments. What can they do? What can we do to make them feel that we will honor confidentiality, that things won't get in their way, this isn't going to boomerang on them, that their words aren't going to be used against them, that we're not going to violate boundaries on them. And actually talking about the technology of even whether using Zoom or something else, how do you want that to work? Do you want to virtual screens, which we'll talk about, or non-virtual screen? Does the client have to stay on the screen at all times, or can they turn off the screen if they're feeling anxious? There'll be a lot of different things here to think about. So explicit discussions of technology confidentiality, you're not going to say HIPAA, I assume, but you can say, you know, that what we're using is a device or a system that can't be listened into by other people, it's encrypted or whatever. Make sure, by the way, you are using a HIPAA compliant device. FaceTime, for instance, is not a HIPAA compliant device, so actually we don't recommend you use that one. Use one of the platforms that is HIPAA specific, so that you can in fact guarantee that there is confidentiality from person to person. If you go to our manual, by the way, there's a whole list of, I think Dr. Semple did that, whole list of HIPAA compliant devices and what you can use and how to use them. Should also warn them there's limitations to protections, and warn them a little bit about this, that you'll try not to be listened in on. You can virtually guarantee you won't be, but you know, it may be that they would be listened in on. So where could they go in the house to be safest? Could they have conversations with supportive parents and sibs about not being bothered afterwards? So something about that notion of limits of protection. You don't want to scare the kid, but also maybe letting them know that you are a mandated reporter, so limits also involve, you know, if you tell me scary things that I may have to act on. We would want a kid to hear that anyway, but it's going to be something you don't want to hear. For most of the platforms, or at least a lot of them, the session can be recorded. This is not something the clients uniformly like. So the first thing we would do is tell them that although it's could be recorded, and they probably know that you promise it won't be recorded. In most platforms, there's a red button, so they would know if it's being recorded, but I would say it anyway. And if you are going to have to record, which some therapists have to because they're being supervised, they need it for hours or whatever reason, that they talk about with the client and they get the client's permission. And you can't, the ultimate thing can't be, no, you have to be recorded. It has to be, you know, how can we do this? You know, if I have to record, I have to record. If you're not okay with that, then I won't record you, but then, you know, we have some problems with therapy. I don't find that, or hear that that's a real big problem, but it is something to be talked about. Especially be aware of the fact that the clients are, especially, you know, our teenagers, hearing stories about how their people's ex-boyfriends or girlfriends outed them by posting pornographic material of them on websites, all this cyberbullying that's going on out there. Kids are going to be afraid that if they're talking about things that are involving their sexual orientation or gender issues or trauma or things they've done that they're ashamed of, they're going to be aware of the possibility that if it's being recorded, that you could put it somewhere else. So you might say, oh, but my kid would never think I would do that. But, you know, one of the things we always have to live with in this world is there's a massive phenomenologic gap between us and our clients. We live in a much safer world than they do, especially in this kind of times. And so we need to really take seriously the fact that they logically would question whether we are not telling their parents that we're putting something on the web, whatever. Dress as you normally would if the session was in person. That kind of goes back to an earlier one. But again, this just kind of means that they don't see a change. You know, this is talked about in trauma therapy generally, that you want therapy to be predictable, reliable, it should look stable, and you should feel that there's nothing about to happen in there that's going to throw you off. And so dressing as you normally would is going to be important. So on some platforms, for instance, on Zoom, there are virtual backgrounds. Therapists like those because what it does is it allows the client to see, it doesn't allow the client to see the room that the therapist's in. There may even be things in the therapist's environment that would be triggering to the client, and we can generally avoid that. But so sometimes therapists want virtual backgrounds. Some clients want virtual backgrounds because in some sense it's TMI for them. They'd rather have, you know, it is different, but at least they're not having to find out stuff they don't want to know or think they want to know. However, we have been told multiple times that some clients wonder what you're hiding if you have a virtual background. You know, suddenly you've got trees behind you or clouds. And this is, again, to remind you that although you might think your client should know that you're a safe person, they probably do on some level, but they don't on other levels. So, and literally, I know it's gross to talk about, but clients wonder whether the therapist is touching themselves or masturbating or something while they're talking about sexual abuse histories, because adults have been sexually transgressive to some of these people. And, you know, we get stories all the time now of, there's a new media thing going on right now about people having sexual contact you know, during Zoom sessions. This can be very, very triggering. So you want to work that out. If everybody likes the virtual background, it's great, but be aware of the fact that it may not be what the client wants. Warning the client about this one. This one came from hard experience, okay? This did not start out on anybody's list, but almost inevitably, well, maybe, what do you think, inevitably, Amy? Yeah, almost inevitably. What's going to happen is it's not going to always work perfectly in the therapist side. So dogs are going to bark, kids are going to start screaming in another room, someone's going to yell at someone in another room, your dog or your kid is going to come up and sit on your lap and stick their face in the screen, etc. So therapists are a little bit mortified about that because it seems like it's so bad. Frankly, I don't think it's rough on the client, it's on the therapist. But what you really want to do is do a warning ahead of time. So, you know, if you say, you know what, you know, if it's okay to say you have a kid or you have a dog, you know, and sometimes the child may yell or something may happen, and you talk about with the client, you know, be very careful because, again, if you include too much personal detail, it feels like a boundary thing for them, a TMI. But some of that you can talk about, and it can really change things. And, you know, I know, for instance, that Cheryl Lankry, who'll be speaking next week with me, has had many experiences with one of our dogs Zoom bombing during a therapy session. And, you know, generally, people like that. It's kind of a relieving, and they sort of want to know that we live in the real world. But again, we don't want them to spend too much time thinking about us in the real world, so you have to strike that balance. This is a cool thing. I'm not sure who this came from. Maybe from Amy. Did this come from you, the next one, the transitional envelope? Yeah,
I think so.
Yeah, I think this is very, very cool. If you do have access to your previous office, at least a little bit, what you might want to do is see if you can find something that was in the room that the client typically saw when they were in the room, whether it's a statue, a figurine, a picture. It could be any little thing that was visible to them before, that you now include that in your video feed. So somewhere behind you, if you're not using a virtual screen, there's a little statue of Jesus or the Buddha or, you know, whatever it might be, or a picture of an open setting. You know, the idea here is what it does is increases safety by allowing them to have a transitional representation of what it was like when they were in a safe environment. They can now do it in a new environment, but have that to hang on to. This may be especially relevant to people who have more serious attachment problems and people who have had very dangerous external environments where they just don't know if they're ever safe. And then obviously you don't want to do this, but we are all human. Don't look at your phones while they're talking to you, or look at other devices off screen. You know, or if you're going to do that, let them know why you're going to do that. Like, I just want to check to see if so-and-so is so-and-so, or maybe you want to find a resource. Turn your phone off so that it doesn't ring during the session at all. Just don't do that. often the client won't feel the entitlement to tell you to pay attention to them, but you can imagine for so many of our people who suffer from abandonment and neglect, disattunement, rejection, it can be very easy for them to feel that way. Think about how you feel about it when someone starts looking at their phone while you're talking to them. Well, that can be amplified too. Okay, what time is it? It's 12:43.
Yeah, we're right on time here.
Oh my God, look at that.
Yeah.
Okay, so now Amy's going to take it from here for a while to talk about examples of increasing psychological safety. She has a wonderful environment and good stuff to say.
Yeah, so to that point about increasing psychological safety and transitional objects, you will see in the background here, I have this gigantic poster that is from my in-person office that I brought back with me. I also brought back my office plants and things like that. So for my clients that were already in the office, I make a point of showing them those objects and being able to have a fidget toy that they really liked when we were in office that I can then use in our sessions via telehealth. Now, myself and many colleagues are now onboarding lots of new clients who've never seen us in the office and we've never met them in person. And for some of us, we end up doing phone sessions with people where we don't even know what our client looks like, which is a very interesting place to be. So a lot of my work is over Zoom. So one of the things I've done when I onboard new clients via telehealth is I do want them to know, which is what you see up here on the slide, that I am part of an organization. I am not just a random nosy stranger in their basement, asking about their trauma history. So I want them to sort of see hey, this is the building where my office is. We have this waiting room, which actually now looks a little different because of COVID. We've had to remove some toys, but I want them to sort of know what our physical office looks like, because for some of my clients, if I need to bounce them into the office for a session to establish safety, I want them to sort of know what to expect. I also have a little video of what my office looks like that I show them in the first session so that they understand those things. And to John's point as well around sort of the other issues with psychological safety, I usually will wear headphones so that the client doesn't have to worry about who's going to overhear me. And I turn my computer screen, which I tell the client, so that if somebody does barge in to my space, I might see them, but that the client will still feel more protected. And then what you'll see on the next slide comes from chapter 5 of the manual on telehealth. And this is over issues. We get lots of questions around administering the assessment process when we are doing teletherapy. Excuse me one second. All right, sorry about that. There's construction noises in the background. So if this were an actual telehealth session, I would have warned the client and said, there is construction in my neighborhood. You might hear some of that in the background. So some things to think through with administration of psychological tests. A big question we get a lot is, we're over telehealth. How do we ask about a client's trauma history? And one of the points we really want to make is that our clients are living and dealing with their trauma history day in and day out, and that it is still recommended to go ahead and do a trauma history as well as a trauma screener as part of trauma-focused telehealth. Because otherwise you can't really do trauma therapy if you don't know what the client's trauma history is. So generally, there's lots of different ways to approach this. Over telehealth, it's often going to be more of an interview rather than our standardized assessment measures that we might do in real in-person work. And in a few moments, I can go ahead and we'll show you an example of that. So one of the things as well we wanted to just orient you to, for those of you who are ITCTA providers, that on the USC website, there's lots of forms that are fillable that make it a lot easier for telehealth, because then I can share my screen, the client can see what I'm seeing, and we can collaboratively fill out those forms together rather than it having to be just me verbally reading them. The other point I wanted to make too is that sometimes you can use which sounds kind of hard to manage from the technology side. I've talked with some people where they actually use more than one web camera. So they'll have the web camera in their device and an external camera. So then they can hold the camera up and show the client like what they're looking at, if it's like an art activity or if it's an assessment measure that they don't have access to over the computer. And so with that, as I'm sure all of you have lived experience with if you're doing telehealth, a big part of this process becomes advanced planning. When I am in the office, something can come up, I can pull my hand out and I am good to go. With telehealth, oftentimes we have to think through what is my theoretical goal for this session? So like, what is the gradual exposure work or the desensitization work that I need to do? How might I do that in an engaging way via telehealth? And what am I going to do if either my technology or my client's technology goes funky and I have to come up with a plan B? So being mindful of having more than one activity ready to go, so that if I might be planning to play a YouTube video related to progressive muscle relaxation and the client is telling me it's too choppy, then I might need to be ready to sort of verbally walk them through the script over the phone so that we can still accomplish the same therapeutic goal. In addition, thinking about how you can intersperse and change up what activity you're doing. So if I am working on some titrated exposure, I might use a screen sharing approach, and then we might use some music to sort of change up the medium while still working on the same theoretical goal can be really helpful. And I think we sort of hit this one here as well, but expecting the unexpected, because that can always happen. So then on our next slide is a picture of sort of the setup that I have. And the big caveat here is that I have the luxury of a desk in my home office, right? Which I know many people do not have. So when it's possible, what I actually did was I brought home a computer monitor from work so that I could have two screens. So I have my laptop and I have a second screen, which allows me to be able to see my clients bigger, which feels more natural to me. And it also helps with the, when you're administering assessment measures. So what you see in this picture, I know it might be small on your screen, but I have the assessment measures are on the big monitor there. And then on the small monitor is the Zoom box. It's actually a colleague, it's not a client, no HIPAA violations here, but the colleague is on the second screen so that I can maintain eye contact with the client while still sharing my screen. For me, I had issues when I was using an iPad where it was just a lot easier with like a computer laptop setup. And I think we hit this point as well of looking at the fillable forms as well. And on our next slide, I actually did a quick sort of demonstration, if that's hopefully our technology will cooperate here. This is the UCLA assessment measure. So this is a measure of a client's trauma symptoms. This is one where I would have already asked for the client's trauma history. And then this is the audio where what you'll see is you'll hear the dialogue between me and the fake client, as well as you will see the client's answers for the assessment measure pop up. And we thought it might be helpful because we get a lot of questions about this to sort of see a super quick, definitely imperfect demonstration here. All right, well, thank you so much for filling me in, Caitlin, about everything that's been going on in your week. You know, when I talked with you last time, we talked about some of the upsetting things and the really tough things that have happened in your life. And so now what we're going to do is these are questions that I ask all of the teenagers that I work with. And for these, I just want to get a sense of how often have you been feeling this way in the last month? So for each of these, what I'll do is I will ask you how often this is. Hopefully you can you see the questions up here?
Yes.
Okay, awesome. So for each of the questions, you can tell me how often something happens. And here is the scale that we're going to be using. Is it none? So that like really never happens, a little, some, much, or most of the time. Make sense? And there's no right answers, there's no wrong answers. This will just like help me make sure that I am not missing anything, and that I can make sure that we're tailoring our work together in ITCT to best help you. So do you have any questions before we get started?
I don't think so.
Okay, great. So for our first question, you'll see here, number 1. I'll go ahead and read you the first few, but then you can go ahead and just tell me your answer to the next one, if that's okay. I'm on the lookout for danger or things I'm afraid of. Now, does that happen to you? None, a little, some, much, or most of the time?
A little.
A little bit. Okay. How often do you think things like, I am bad?
Some.
Some. All right. Do you want me to keep reading, or do you want to just sort of read and tell me your answers?
I can read and tell you my answers.
Okay, so for number 3?
Much.
Much. All right, number 4?
Some.
Okay, thank you so much. Basically, when I'm able to share the screen, I'm able to give the client, like I will explain the measure, I'll give them time to where they can read and just tell me their answers rather than me having to necessarily read all the questions. And then on the next screen are some examples of different activities that I have found to be really fun with clients in the context of trauma therapy and telehealth. So one, I can't say enough good things in my experience with Zoom about the whiteboard feature. So the picture in the top left that has good and bad is a relational processing activity that I did with a 13-year-old young man. And he was discussing his relationship with an offender, and he was sort of rating the number of bad interactions he'd had with this person versus the number of good interactions as a way of talking through like how he's viewing his present relationships. So what he did was I drew the good and bad, and then on his side, he added in the hearts and the other things. So it was coming in live over the course of the session, which was pretty neat. The mail is another thing that I wish I was better about doing, but every time I do it, it's very fun. But someone I consult with gave me the idea. They took a blank puzzle and they would send the clients pieces of the puzzle each week that would then get put together with a message from the provider as a way of increasing the rapport and things like that. There's also lots of fun activities that you can do. So there's the wheel, which is from Wheel Decide, which is online. It allows you to put in different therapeutic, well, you can put in whatever you want. I like to put in different therapeutic activities, and then the client can spin the wheel, and then that's how we help pick which activity we might do if it's a mindfulness activity or things like that. And then the last picture I have up here is of finger puppets, because there's so many different ways to have fun while doing teletherapy. And I found even my grumbly teenage clients are willing to go with me on using the finger puppets. So like if they are describing a situation, I might say, okay, this is you and this is your girlfriend, like walk me through it. And then they'll verbally narrate a situation, or they might narrate a situation that was part of their trauma experience. And then I will act it out. And it's a way of sort of helping to draw their attention to something other than like just my face and my voice and my hands. So these are all just a few different examples of activities that myself and our team here in St. Louis have found to be helpful in the context of this new avenue of teletherapy for children and teens impacted by trauma.
Thank you very much, Amy. This is just to give you an idea, we have a little bit more to talk about, but this to give you an idea about next time. Today I was focusing a lot on logistics and safety, et cetera. Next time, the next presentation, which you see on the screen there, Wednesday, November 18th, we'll address threats to rapport. I said that it's complicated, but we can do things about it. A lot of people talk about, can you still do emotional processing, therapeutic exposure? And there are things you can do, but also constraints. Involving and supporting family members. Cheryl is a child family person too, more than I am, and we'll be talking about how to integrate family work into this work with the kids. And then lastly, some of you are already starting it, although I wouldn't get too wouldn't assume that you're not going to have to go back again later, but returning to the office, how do we do that? So the APA and a number of different organizations have pretty much said, when should we return to office, or should we, depending on a variety of things. We also want to share with you that we have a special event guest speaker. You see the link there. This is the well-known Russell T. Jones, who's a pretty famous guy in the area of specifically burns, which some of us are very interested in, also trauma in the environment and disasters, et cetera. But he does some really good work working with therapists to see what the experience of African American people of color would be in different contexts, and to understand how we can work to be more anti-racist and more supportive in those domains. Russell gave a brief one of these for our consultation group a few months ago, and it was a huge success. We were hearing about it for weeks afterwards. This is a guy that's not only really smart, but he's deeply compassionate, non-judgmental, supportive, and all-around great speaker. So if you have a chance to hear him, you might want to do that. The registration button's on the bottom there. I don't know how, Randy, they can't actually click on that, right?
Yeah, John, I just put it in the chat for everyone.
Oh. And here's just some references for today. I think that probably, it looks like there's 79 questions, or if I'm reading that correctly. There are over 500 of you on this call, and we just could not handle the bandwidth issues associated with answering the questions. So just on this one, with your questions, I'll have to go unanswered. You can, of course, email whomever and ask about it, but please forgive us for that. We just had, that was the compromise that we had to make in this circumstance. So I think it's almost exactly on time. Let me see if
and we again just want to remind you, at the USC site, you can download both the ITCTA manual. There's also fantastic substance use, self-induced behaviors, a wonderful mindfulness manual, as well as the telehealth adaptations, and lots of other good things I'm probably forgetting about.
The working with self-injury is another popular one in that group. Yeah, so thank you, Amy. So we have a lot of manuals. Manuals are what we do, and they're all free for you. They're PDFs you can download from the website there. Feel free to use them even if you're not in ITCT, even if you do other therapy modalities. We try to write them so they'd be relevant to everybody. Well, so that's it. Thank you, everybody, for listening in. Feel free to, and I hope you will, log on to the next one of these where we'll be covering the rest of the issues that we had planned for. Are we done?
All right. Bye. Thanks, everyone. Thank you for the work you do as well.